Dear colleagues, this lecture is about the genesis of cardiac arrhythmias. The normal heart rhythm is generated and driven by spontaneous firing of pacemaker cells of the sinoatrial node located in the posterior wall of the right atrium. These cells have an intrinsic firing rate of 100 to 110 depolarizations per second. However, this intrinsic rate is under control of autonomic nervous system. At rest, the sinoatrial node may be in the range of 60 to 80 beats per minute, which is well below the intrinsic firing rate of the SA node. This reduced resting rhythm is due to vagal tone. The efferent vagus nerve fibers innervating the SA node normally have a high level of activity under resting conditions. These nerves release acetylcholine, which binds with muscarinic receptors on the SA node cells to cause decrease in firing rate. The sinoatrial node is also innervated by sympathetic fibers. These autonomic nerves release norepinephrine, which binds principally to beta-1 adrenoreceptor located on the SA node. When the activity of the sympathetic efferent nerves is increased, the SA node firing rate is increased. This is the conductive system of the heart and the mechanisms of arrhythmias, either disorders of impulse formation or disorders of impulse conduction, or both. In the normal sinus rhythm, the impulse generated by the SA node travels through the atria and converge at the AV node, where the speed of conduction is reduced. Impulses from the AV node travel into the ventricle via the His bundle, then bundle branches, then Purkinje fibers, and finally are conducted to the ventricular myocytes. This is the action potential composed of phase 0, upstroke or rapid depolarization, phase 1, early rapid repolarization, phase 2, plateau, phase 3, final rapid repolarization, and phase 4, resting membrane potential with slowly uprising is called diastolic depolarization, and the rate of this diastolic depolarization defines the heart rate. Again, this is the action potential, and the phase 4 is only present in the pacemaker cells. The resting potential, when it spike or it charge or impulse starts to increase till reaching 90 millivolt, it initiates impulse. So the threshold of electricity in the pacemaker cell is 90 millivolt. This is recording from inside the heart. The atrial activity is called A wave, His bundle H wave, and the QRS V wave, and the AH interval and HV interval is this recording is normal. And this is how we record from inside the heart. Catheter multipolar or quadripolar in the coronary sinus and in the His bundle, another one in the right atrium, and another one in the apex of the right ventricle. Arrhythmia can be due to either abnormal impulse formation, triggered activity or automaticity, and re-entry. The abnormal impulse formation can be either early after depolarization or delayed after depolarization. The after depolarization is recorded by the Holter apparatus. It records, say, 1000 QRS over each other. The normal, there is no discrepancy between the QRS wides. It is less than 40 milliseconds. If it is more than 40 milliseconds, it is abnormal after depolarization. The voltage clock refers to voltage-sensitive membrane currents, such as hyperpolarization, activated pacemaker current. This current is also referred to as funny current because unlike most voltage sensitive currents, it is activated by hyperpolarization rather than depolarization. The depolarization activates the calcium channel, which provides calcium to activate the cardiac ryanodine receptor. The activation of the ryanodine initiates sarcoplasmic reticulum calcium induced calcium release, leading to contraction of the heart, a process known as electric coupling. The IF current, the Fani current, plays a major role in initiating the diastolic depolarization of the sinoatrial node cells. Types of arrhythmias. Arrhythmias can be altered rate, premature beats, altered conduction, altered rate either below 60 bradycardia or above 100 tachycardia. Atrial tachycardias have rate of 250 to 350. In the ventricle only more than 200 are called flutter. Can be either atrial or ventricular. Fibrillation occurs either atrial or ventricular when frequency is so high and irregular. There is one type of arrhythmia called parasystole is a kind of arrhythmia caused by presence and function of a secondary pacemaker in the heart, which works in parallel with the sinoatrial node. Parasystolic pacemakers are protected from depolarization by the sinoatrial node by some kind of entrance block. This block can be complete or incomplete. Parasystolic pacemakers can exist in both atria and ventricles. Atrial parasystole are characterized by narrow QRS. This is example. This appears to be atrial premature beat, but when you count the interval between the premature beats, you found it fixed and not related to the basic rhythm. Also, ventricular parasystole. This appears as if ventricular premature beat, but if you count the interval between the premature beats or the parasystole, they are equal or multiple of equals. Like this. Here the premature beat, the same interval, 1690 millisecond between each premature beat, and is not related to the basic cycle length. Altered conduction delays in the conduction of electrical impulses within the heart produce abnormal electric activity. Conduction defects. If PR prolonged first degree block, if AV conduction is depressed sufficiently, leading to loss of one-to-one correspondence between atria and ventricles, is called second degree block. If there is complete dissociation, it's called complete heart block. Sick sinus syndrome, a disturbance of SA node function that results in markedly variable rhythm, is called bradycardia tachycardia syndrome, and the hallmark of sick sinus syndrome that the rate does not increase with atropine above 70 is associated with some degree of block and variable attacks of bradycardia and tachycardia. So to diagnose person with sick sinus syndrome, you have to find one of these features. Rate slow at rest but does not increase above 70 with atropine. They're associated with some degree of block and associated with attacks of bradycardia and tachycardia. Atrial tachycardia is more than 100, atrial flutter 250 to 350. Junctional escape rhythm. SA node suppression can result in AV node generated rhythm of 40 to 60 is called escape, junctional escape, not preceded by P wave or just by inverted P wave. Atrial fibrillation. The pathogenesis of atrial fibrillation is an interaction between initiating triggers, often in the form of rapid firing ectopic foci located inside one or more of the pulmonary veins, and an abnormal atrial tissue substrate capable of maintaining arrhythmia. Pulmonary vein triggers may play a dominant role in the young patient with relatively normal hearts, and short paroxysms of atrial fibrillation, whereas an abnormal atrial tissue substrate may play a more important role in patients with structural heart disease and persistent or permanent atrial fibrillation. Focal atrial fibrillation, it is now known that foci of rapid ectopic activity, often located in the muscular sleeves that extend from the left atrium into the proximal parts of the pulmonary veins, play a pivotal role in the initiation of atrial fibrillation in humans. Less frequent focal initiation of atrial fibrillation may result from ectopic activity that arises from muscular sleeves in the proximal superior vena cava, ligament of Marshall, other parts of the right and left atrium or coronary signs. Deceleration dependent block is that we always know something called diastolic depolarization. Bradycardia dependent block is caused by conduction block at slow rates, and the tachycardia dependent block is caused by block at rapid rates. Decremental conduction, some stimulating efficacy of the propagating action potential diminishes progressively. So the impulse focus diminishes progressively is called decremental conduction. Re-entry, various names of re-entry or circus movement or reciprocal or echo beats occur as one of the causes or mechanisms of arrhythmia. Entrainment represents capture or continuous resetting of the reentrant circuit of the tachycardia by pacing induced activity. We stimulate the heart by progressive repeated impulses at a rate faster than the tachycardia present. It captures the initiation of the tachycardia, is called entrainment. This helps in the delineation and localization of the site of the arrhythmia. The criteria of entrainment can be used to prove the reentrant mechanism of clinical tachycardia. Basis of localizing and mapping the pathway traveled by the tachycardia wavefront by entrainment. Localization is essential for ablation. So entrainment is one of the methods of mapping of delineation of the site of the arrhythmia. Supraventricular tachycardia usually caused by reentrant currents within the atria, ventricular premature beats caused by ectopic ventricular foci, ventricular tachycardia high ventricular rate caused by aberrant ventricular automaticity or intraventricular reentry. The ventricular tachycardia can be monomorphic or polymorphic. AV block, a conduction block within the AV node. We mentioned this either first degree prolonged BR, second degree sudden failure of conduction, or progressive prolongation of PR, or 2-to-1 block. In fact, second degree AV block is divided into three types. Mobitz type 1, progressive prolongation of BR till there is failure of conduction. Mobitz type 2, sudden failure of conduction without previous progressive prolongation. And the second degree high grade persistent constant block 2-to-1 or 3-to-1. So second degree AV block is three types. Third degree AV block is complete AV dissociation. This is example of supraventricular tachycardia. Here after the QRS there is notch. This is P wave. The P wave, if it is after the QRS by more than 70 milliseconds, most probably it is accessory pathway and is called AV reentrant tachycardia. But in this case, it is called AV nodal reentrant tachycardia. The fast, regular, and narrow paroxysmal supraventricular tachycardia due to re-entry inside the AV node is called micro re-entry, and when it occurs due to accessory pathway outside is called macro re-entry. Inside the AV node, the impulse may pass in the fast pathway and return in the slow, or pass in the slow and return in the fast. Typically, premature atrial contraction block in the fast pathway and conducts down the slow pathway, then back in the fast pathway, initiating AV nodal reentrant tachycardia. Anatomic re-entry. The two pathways have different electrophysiologic properties. Short refractory period and slow conduction in one pathway, and long refractory period and fast conduction in the other. This dual physiology in the AV node may precipitate attacks of supraventricular tachycardia. The impulse is first blocked in one pathway with longer refractory period and then propagates slowly in the adjacent pathway whose refractory period is shorter. If conduction in this alternative route is sufficiently depressed, the slow propagating impulse excites tissue beyond the blocked pathway and returns in the reverse direction retrograde along the pathway initially blocked to re-excite tissue proximal to the site of block. Again, this is the mechanism of the dual physiology, a slow pathway and fast pathway. The impulse passes in the slow pathway and returns in the fast pathway. Again, there is block here, but the block is antigrade only. There is no retrograde block. The impulse returns retrograde. Again, this is the impulse blocked antigrade, but returns retrograde. This is 2 to 1 uh, atrial tachycardia, and then the impulse becomes 1 to 1 conduction. Just by slowing the atrial rate, it became 1 to 1 conduction. The 2 to 1 here is atrial flutter. This is intracardiac recording during supraventricular tachycardia. The atrial activity and the ventricular activity are in the nearly the same line. So this is micro reentry inside the AV node and the AV-NRT. Here, example of Wolff-Parkinson-White syndrome, typically characterized by short BR, delta wave due to some early repolarization of the ventricle, and QRS wider than normal. So these are the three criteria. Atrioventricular pre-excitation, Wolff-Parkinson, accessory pathway that conducts from the atria to the ventricle. Simultaneous conduction creates fusion beat with a delta wave. Atrioventricular pre-excitation may proceed up or down the accessory pathway. If it is starting from down the accessory pathway, it is called antidromic. If it is from the atrium to the ventricle through the normal pathway, is called orthodromic. The orthodromic conduction can surface ECG does not show delta wave, does not show short BR, and is called concealed conduction. This is typical atrial flutter, atrial fibrillation with variable RR interval and wide QRS, and the delta wave is apparent. So this is classic atrial fibrillation in accessory pathway. Immediate cardioversion, then schedule for ablation without delay. Here this is supraventricular tachycardia, but there is apparent P wave after the QRS by more than 70 milliseconds. So this is AVRT, but as long as there is no delta wave, we call it concealed conduction. The impulse passes from the first in the normal pathway, orthodromic, and returns retrograde in the accessory pathway. So there is no apparent short BR and no delta wave. Long QT syndrome, the genesis of long QT associated with VTAC and VF, action potential prolongation may increase influx of calcium through L-type calcium channels during cardiac cycle and cause excessive accumulation of calcium in the reticulum and spontaneous release of calcium from the reticulum. Elevation of intracellular free calcium depolarizes cardiomyocyte membrane potential, thereby evoking early depolarization that initiates ventricular tachycardia. This is the long QT. Now we come to atrial flutter. This is example of atrial flutter with 4 to 1 conduction. This is how we put the caster in the Koch triangle to ablate the atrial flutter. Atrial flutter with typical and atypical. The typical is anti-clockwise. Now we come to ventricular tachycardia. Dr. Nabil Sharif in New York, professor, the first one to initiate or suggest the mechanism of eight as a mechanism of ventricular tachycardia, the impulse re-entry around a scar. And when we ablate at the exit or inlet of the cycle. This is the place of ablation to ablate the ventricular tachycardia. Ventricular fibrillation is maintained solely by re-entry. Recent investigations concepts of restitution kinetics, wave front and wave break, focal discharge, and rotor. Hassaguer in France is the first to suggest or initiate the theory of rotor as a replacement for the classic re-entry theory. The hallmark of cardiac fibrillation is ongoing wave break or wave splitting. Wave break is caused by conduction block occurring at a specific site along the wave front while remaining portions of the front continue to propagate. This is the mechanism of ventricular fibrillation. This is example of ventricular tachycardia. When you see this is left bundle pattern. The QRS shows small r but wide S. The wide S is showing left bundle. Left bundle should have left axis, but here there is right axis. QRS above in lead 3 and down in lead 1. When you see left bundle ventricular tachycardia with right axis, the site of origin is right ventricular outflow tract and most probably AV abnormality in the right ventricular outflow tract. Brugada syndrome, phase 2 re-entry in the genesis of ventricular tachycardia fibrillation associated with inheritable Brugada. Brugada syndrome is due to abnormality in the epicardium with depolarization different from timing from depolarization of the endocardium. This in dispersion of refractoriness initiates the ventricular fibrillation. Loss of function mutations in the channel 5, which encodes the pore forming cardiac sodium channel, alterations in the sodium channel current, heterogeneous loss of the action potential dome during plateau phase in the right ventricular epicardium leads to marked dispersion of repolarization. So remember this word, dispersion of repolarization or dispersion of refractoriness in the epicardium leads to ventricular fibrillation. Ablation of the right ventricular epicardium eliminates the ventricular arrhythmia. Arrhythmogenic right ventricular dysplasia is inherited disease characterized by sustained monomorphic VTAC and sudden death, mutations in the proteins of the cardiac desmosomes. Inherited arrhythmogenic diseases constitute an expanding field with a wide spectrum of electrocardiographic manifestations. Mutations in the same gene may cause different phenotypes. Both tachyarrhythmias and bradyarrhythmias in structurally normal heart may be genetically determined. Thank you. I hope the lecture was not difficult. It is as mainly about genesis of arrhythmia, and I will put it on my channel on YouTube. I hope when you see the channel, you put subscribe to make it more apparent to others. Thank you and best wishes.